Hi, I'm Dr. Jordan Tishler. I am a cannabis specialist at Harvard Medical School, and I have a private practice, inhaleMD. I'm very grateful to the EDS and HSD societies for having me on to speak with you all today. A quick bit about myself so that you understand a little of the background. I trained at Harvard Medical School and the Brigham Women's Hospital. I worked in emergency medicine for many years at the VA prior to my becoming interested in cannabis medicine, which led me to forming the private practice I mentioned, inhaleMD. It was through that experience that I ultimately moved on to founding the Association of Cannabinoid Specialists, which is an organization focused on training physicians and other clinicians how to take proper care of patients using cannabinoid medicines and to help advocate for better tools for the care of patients at the state, national, and international levels. And just as a matter of course, I want to say that I have no conflicts of interests that I must report to you guys. Now let's get to talking a little bit about what cannabis and cannabinoids can do for us. Number one on the list is the treatment of pain. Certainly this is an issue for folks here today. And what we know is that cannabis works effectively for pain management. It's much safer than the opioids that are commonly used. And so as we are thinking about pain management and sort of going down the list of things that we can try, it is my firm belief at this point that, that we should be looking at cannabinoid medicines prior to the institution of opioid medications. It's also important for us to know that these things are not mutually exclusive and that oftentimes we may need some cannabinoids and some opioids, but that ultimately by using cannabinoids in conjunction with opioids, we can use far less of the opioids and expose ourselves to less risk. Other illnesses or symptoms that go along with EDS and HSD include things like anxiety and depression. This is an interesting area where cannabis can be helpful or it can be harmful depending upon how it is used. Common wisdom suggests that the appropriate treatment of depression and anxiety with cannabis would be to use cannabis sort of all day long. We know that that is incorrect and that that can actually backfire and make depression and anxiety worse, but that small doses typically given in the evening prior to bed can actually be very effective. And one of the things that's interesting about that to me is that it's not about being intoxicated. That's really a side effect, but ultimately it is a direct chemical action of the cannabinoids in the central nervous system that leads to these benefits. And the importance of that is that we can use these low doses in the evening and get benefit to anxiety and depression throughout the next day without being intoxicated during the day. Often associated with all of this is insomnia. I think of all the things that cannabis can treat, insomnia is the thing it treats best. There are different types of insomnia, and the approach to that with cannabis depends upon the particular type. But suffice to say that, again, low doses given around bedtime can be very helpful. Eating issues are another area where cannabis can be helpful. It's important for us to make the distinction between the term anorexia that you see in the number 4 slot here, which is the medical term for difficulty eating, from anorexia nervosa, which is a behavioral health diagnosis where cannabis can actually be harmful. But for folks who have simply difficulty eating, often associated with nausea and vomiting, as you see in number 5, cannabis can be a helpful medication. And number 6 is one that I don't want to spend a ton of time on, but I think it's a very important and under-discussed issue, particularly in patients who have issues around hypermobility and issues around general pain syndromes. The sexual dysfunction is a huge impact on people's lives and relationships. And cannabis, again, if used carefully and appropriately, can be helpful for that. I also should mention that I'm working on a book on that, and more to come on that as it gets closer to publication. There are, however, a few elephants in the room that I think we should address, particularly of concern to not only people with EDS, but also to their parents and caregivers. And so the first amongst this is, well, okay, fine, Dr. Tishler, you say that cannabis can be helpful, but we don't want any more problems. So let's talk about, isn't this stuff addictive? And I think that it's important for us to remember that the word addiction is a little bit misused in common parlance. And what we really want to be focusing on is dependence. Dependence is a biological issue where our bodies get used to a substance, and then if we stop it, our bodies grumble and complain at us, and these are called withdrawal symptoms. And yes, we can see that in cannabis. It's fairly rare, and more on that in just a second, as opposed to truly an addiction, which is really a set of maladaptive behaviors that arise around a substance use. And typically, we don't see that very often in cannabis users. It can happen, and that's really what we call cannabis use disorder. But if we're being very mindful of dosing and timing, these are things that we can stave off. Now, to put this in some context, we can look in the middle of the slide and look at sort of lifetime dependence risk of various substances that are well known. So in general, we think that the lifetime risk for cannabis use is about 7%. And if we compare that against nicotine, which has a 32%, opioids, which have roughly 23 to 25%, benzodiazepines 18%, cocaine 17%, and our dear friend alcohol at about 15%, you can see that the risk of dependence from cannabis is about half that of alcohol, which is the lowest on this list. It's also worth noting that of all the substances on the list, except cannabis, the risk is fairly constant, meaning whether you start using opioids at 18 or 40 or 80 years old, your risk is still roughly around that 25%. Cannabis is different in that the risk is front-loaded, meaning younger folks have a higher risk of developing that dependence, roughly about 18%, which puts it in the range with the benzos and the cocaine. But if you make it to the ripe old age of about 25, then that risk drops down to about 2 to 3%. So again, as we think about this for younger folks, we have to be a little bit more thoughtful about the risks associated, but in older folks, those risks diminish considerably. It's also important for us to say, well, okay, now we talked about the risk, but what's the reality? What does a withdrawal look like? And thankfully, withdrawal from cannabis is fairly benign. It's typically about a week of insomnia and crankiness, mood instability, irritability, that sort of thing. Often that's sort of the things that we've been treating in the first place, but this is something that we have to be on the lookout for. The second question that often comes up are around cognitive issues, or put another way, will cannabis make me stupid? And the answer to that is very interesting. For years, decades really, as you may be aware, there's been a lot of science, often funded by the US federal government, trying to find harms from cannabis. And so cognitive issues were amongst those, and there were many studies that used techniques like IQ measurement and MRI and functional MRI that have looked for various indicators of cognitive function. And it's important to understand that all of those studies were done in what were called healthy volunteers, which is another way of saying recreational users or stoners. And that's not a very good representative population for what we really want to know about, which is our affected patients, or in this case, perhaps family members. But what we know from those healthy volunteer studies was that we can see about an 8-point drop in IQ, specifically in the area of verbal memory, and that we don't see any change in executive function, spatial, or quantitative functioning, and that these changes are only seen in the range of 20 to 30 years of heavy use. The definition of heavy use is a little bit unclear because all of these studies in healthy volunteers were done without knowledge of what the actual amounts, but we can infer that they were significant amounts. Now, coming into the more recent times, we've started to ask the question, how does cannabis impact cognitive function in patients? And interestingly enough, studies have shown that the cognitive function improves. You say, well, wait a minute, how does that make sense? And I think the important answer to that is that when people are sick and uncomfortable, quite frankly, they're not at the top of their cognitive game. And by giving them pain relief or other relief using cannabis, we can actually then make their cognitive function better. Doesn't mean that their cognitive function is as good as if they didn't have their illness, but it is as good as we can make them. And that's, I think, an important distinction. Undoubtedly, you've seen a lot of discussion about various ways in which we can use cannabis, and it's very important for us to understand that there are different ways and that they lead to different outcomes, so that we need to choose the appropriate approach for the illness that we're trying to address. And furthermore, that there are ways that we can use cannabis that frankly aren't helpful at all. So top on this list you can see is smoking, and generally speaking, I don't recommend smoking to anybody because smoke isn't very good for us. But smoking is one approach to the broader category of inhalation, and inhalation is important to us because it has characteristics that we can use. It's rapid onset. It starts working in sort of 10 to 15 minutes, which is very quick for any kind of medication. And it's also relatively short acting, so it wears off in 3 to 4 hours. This makes it really useful for acute problems or episodic problems. And a classic example I would give is kind of a migraine type headache, where we don't have a lot of warning that it's coming on, and that we know that once it starts, we need to get in there and treat it very quickly so that it doesn't get out of hand. So if we want inhalation and we don't want smoking, then we're talking about vaporization. You can see in the slide here that we have two types of what are called vaporizers. We have the vape pen. This is not a safe device. The more we learn about these devices, the more we learn how dangerous they are in terms of producing toxins and also inhaling heavy metals. The thing above this with the spout and the fin is a flower vaporizer, and that's a much better tool because it is in fact controlled with a little microprocessor, a little computer chip that allows us to set and maintain the appropriate temperature, and that's the key to getting the medicine off the plant material without creating any of these toxins. On the other hand, we have things like these little gummies that are often called edibles, and they are not a direct substitution for inhalation because their action is very much sort of the opposite. So where the inhalation is rapid and short, the edibles are slower to work, but once they do start to work, they work for longer. So we can think of the edibles as kind of our extended release medicine, and that makes them much better for pain management, the kind of pain management that we're probably thinking about today for EDS and HSD patients. Clearly, edibles come in lots and lots of different form factors, and clearly we would like to spend some thought on getting something that has low calories and low fat and not a lot of sugar. And so little gummies like this make a good example, and Rice Krispie treats and brownies are probably not so good. Tinctures are a liquid form of cannabis. People talk about you put it under your tongue. We actually know that nothing happens if you put it under your tongue. On a chemical level, there's a little bit of a psychological event that happens, but that really the medicine only works once you've swallowed it and it's been absorbed. I tend to recommend staying away from tinctures actually, because tinctures are liquids, and dosing is the real key to making this work properly. And with a liquid, it's very easy to make a mistake with a dose. So I think that the tinctures tend to be sort of a setup for problems. And then there are cannabis topicals, meaning creams, lotions, and patches, and that sort of thing, which would seem like a wonderful idea for pain management in EDS and HSD patients, except for one problem, which is the cannabis, the cannabinoid medicines in those creams and stuff will not penetrate through your skin. And so they're effectively very expensive and completely useless. So I wouldn't waste your time and your money on those. As I've mentioned many, many times, the dose is the key element. And looking at this little chart here, you can see that sort of as we increase the dose, we can find that we get to a sweet spot on this curve where we are getting the maximum benefit with the minimum of side effects. And that's really what we want to achieve. But the important point is also that once you pass that, once you exceed that amount in the dose, what we find is you don't get better response. All you get is more side effects. And so the dose, again, is key. In my clinic, 10 milligrams is really kind of an average dose. Comparing that to recreational users who are using 50, 100, 200 milligrams, you can see that the medical approach here to achieve best results is a tiny, tiny fraction of what people generally think about. So thinking about that dose and being mindful and focused on it is really important. And we really don't want to be sending people home just to be doing bong rips. We want to mention just briefly something that is, pervasive issues in the cannabis industry. There is a whole lot of marketing discussion around all the different types of cannabis, which are often called strains. And there are over 7,000 of them. And the message that you'll get from this industry is, keep buying different ones, trying them out until you find the one that sort of magically works best for you. And that's really good for selling a lot of weed, but frankly speaking, isn't accurate. As far as we can tell from both clinical experience and scientific experiments, these different versions, these strains, don't make any real difference to medical outcomes. And this includes the entire indica versus sativa thing. These are categories into which these strains often get placed with the intention of saying that the indicas behave this way and the sativas behave that way. And what we know is that chemically they are completely indistinct, meaning there's really no difference. And it's just a good way of selling you twice as much of the product. So ultimately what we need is safe cannabis. Typically, I suggest that people get sort of medium potency, 15 to 20% varieties, because those are the ones that do seem to be most effective. But in terms of chasing specific varieties, I don't think that there's any utility in that. And then there's our friend CBD. As you know, CBD has become legal to sell, and it is available online and pretty much in every corner drugstore and food store. However, it's interesting that in the lab, in test tubes and in mice, there's some evidence that CBD might be useful, but the studies in human beings are really just not there yet. And in fact, many of those studies that have been done really have failed. So what I would say is that CBD at this time really makes a better product to sell than to use. The complication is that CBD is not entirely benign. That is to say, I think the messaging is CBD can't hurt you, but in reality, CBD can interact with a whole bunch of other medications, many of which you guys may be on, and that can be potentially dangerous. Here's a little bit of a slide that talks about this. This is the slide of the drug interactions that people were Googling. And as you can see, thankfully, there aren't that many. Here's one, which is Nexium or esomeprazole, a commonly used antacid. But most of these medications were not a real problem. On the other hand, this slide is the medications that I was worried about. And you can see in this slide, there are far more red Ys for very dangerous medications. Amiodarone is one, the tacrolimus is another, and warfarin or Coumadin is yet another. And these are medications that are very commonly used, and we want to avoid making their blood chemistry altered by using CBD. One that's not commonly talked about, but I think is going to become a big issue, is Claritin or loratadine, which of course everybody knows is over-the-counter antihistamine. But in high doses, Claritin can cause fatal cardiac arrhythmias that really can be dangerous and lethal. So combining Claritin with CBD may in fact turn out to be a potential problem. And that really is it for today. There's certainly much more to be said, but I wanted to be cognizant of the time. If you wish to reach me and ask more questions, please feel free. That's what I'm here for. You can start by going to my website, inhaleMD.com. We've got over 200 articles on various subjects related to cannabis medicine that are all written for normal people such as yourselves. It's a good place to start. There's a search bar, and that will allow you to hone in particularly on what you're interested in. And you can also email me directly at doc@inhalemd.com. Lastly, if you really want some of the deeper science on some of this, you can follow this bit.ly link and download a PDF of a whole bunch of studies that you can read. So thank you for listening. I want to thank the organizers at the Ehlers-Danlos Society for putting this all together. And I look forward to helping you all with your journeys as we go forward. Thank you very much.